Most providers don't struggle with the injury, they struggle with everything around it. And the main thing is the mechanism. You're on People Out here. Welcome to another lesson from the trap. All right, so today's segment, I want to talk about workers' comp and urgent care, how to approach it. All right, so in the ER, of course, you don't really deal with workers' comp, and then primary care, kind of sort of sometimes, depending on the relationship. So a lot of this stuff is going to fall on the urgent care providers. So if you don't work for an actual company that just strictly does workers' comp, and you just working in the urgent care, and of course, we did not learn this in school, so this is one of those areas where it's just on-the-job training, and hopefully, you did get some kind of instructions or advice on how to do this. But like most everything in this role, data storage is out there and we have to figure it out. All right, so the first most important thing is the mechanism. What happened with this injury? How did it actually occur? So I've worked for an urgent care that we had a lot of workers' comp. I've worked for companies where I did strictly just a workers' comp. And then I currently work at a job site where it's workers' injuries, but it's on a job site, so they like to kind of do things just straight first aid. And so it's practiced differently at each different place. For instance, so let's say somebody is like a carpenter or something like that, where they're constantly doing like a repetitive motion. So there was no specific injury, just, oh, I've been doing this for 6 months and now I have shoulder pain. Then you ask them what they do. It's like, oh, well, it's because of what I do. I just hammer all day long. Now, some companies will say, well, there was no actual injury there. So going back to my clear framework that I mentioned in a previous video, that's part of the story. But again, it depends on the employer. And so it may be something where you have to call and verify or how your company operates, because I work for some places where they don't consider those repetitive injuries, they don't count those. And so they will basically kind of deny the case. So they'll say, oh, this is personal medical. And it is unfortunate because, again, the patient comes to you because of this. Nothing actually happened. They didn't fall, they didn't twist anything, but because of the type of work that they do. Just one of those unfortunate things that comes with the type of job that you have. So yeah, sometimes they'll shut it down. Or I've worked at places where they do take those kind of repetitive injuries and things like that. So that definitely getting the clear story on what happened and then following the policy of your particular place. But I would definitely talk to somebody about it. So, and then another thing, there are patients that have like histories of something, like a very common one that you're gonna see is back pain. Everybody has low back pain. I mean, depending on what job you have, everybody has had low back pain at some point in their lives, okay? So definitely, is this something where they were at work and they just so happen to have a flare up on this back pain? Because some people will do that. And then you got the population that, they try to take advantage, and they knew they had something going on and then just so happened to happen at work. I've seen all sides of this. I've seen, the patients that are fearful to even tell the company because they are afraid that they're going to get fired. Sometimes that does unfortunately happen. And they have the very minimal injuries and they try to sue the company, they try to get paid, they don't want any things like that. So it can be challenging sometimes depending on the situation, but the majority of the cases, they're gonna be pretty straightforward, okay? So definitely get the mechanism, get the story. I don't care how many times they told the front, I don't care what they wrote down. Ask them questions, because a lot of times they may not even know, but I definitely dig in and I extract all that information from them as often as I can. So after you get the mechanism, which is really the most important part, the next part that providers tend to struggle in is documentation. Documentation is not just the note, that is the entire case. So that definitely has to be on point, okay? So depending on where you work again, so I work for companies, like typically if you work for a strictly workers' comp place, documentation is usually very nice. It's all computerized, and I know a lot of the places where you have to have the chart done before they even leave. So I actually like working in those settings, and I would do that on the side sometimes. But yeah, there's no lingering charts or anything like that. It's usually, there was one company I worked for, it was just like zero narrative. I just had to click certain buttons, and so I was done like literally in the room, like with the patient. And so you have that aspect, and then depending on the state that you're in, so I'm in Texas, and we have what's called the TWIC form, the TWC. But every state has their own version of it. And so that's usually standard. Usually the company that you work for is gonna have that built into the system. And then certain companies, they also have their own. Like I know Walmart does it, Amazon sometimes. Here in Texas, we have this grocery store called HEB. And so certain companies, they have their own form. So you may end up filling out 2 or 3 different forms, all doing the same thing. And then you have to do the stuff in the computer as well. So that part can be a little time consuming and frustrating sometimes, but it is what it is, okay? So definitely make sure that you are charting everything. So again, that's where the case is gonna kind of determine, okay? So you definitely want to make sure that your documentation is on point. All right, so again, as far as how to approach these things, so you get the good story, get the mechanism, documents, like the case depends on it because it does, and then it's like from there, what are your interventions that you're gonna do? So a lot of it is gonna be orthopedic injuries, and so most of the time, you're gonna have x-ray. You're just gonna get it, even if it's a sprain. Most of the times they're just gonna do it, and depending on the text and how things is set up at where you work, they usually just automatically do it. It's just one of those things that they like to just kind of cross off the list. So the majority of the time, you're gonna just get that x-ray, okay? And then the next part is restrictions. And so again, nobody taught us this. So hopefully you had a mentor, medical director, somebody that kind of walked you through how to do it, but I know I didn't. I just had to figure it out. And so that's another downside to this role, and that's the main reason why I started this platform, is to help. So I have 9 years experience. I've done tons of workers' comp cases, hundreds, and so I'm pretty familiar with it. But yes, so with restrictions, so I always think of the patient first, trying to get them back to where they need to be. So again, of course, you're gonna have the patients that, will wanna stretch things out, but the goal of it is to rest that area. So if it's a wrist, usually they're gonna get probably a brace or just an ace bandage, but you don't want them really using that arm. So when you get to the part about like reaching, typing, keyboarding, definitely with the lifting, I usually fully restrict, especially the first visit. So I'm gonna put a lot of restrictions on there where they're not even really gonna use that arm. And also it depends on what they do. Like certain jobs, they're not able to. They're not able, like teachers, for instance. That's very common profession that I see. And I feel really bad for teachers. And usually the ones that I see are like the ones that take care of like autistic or special needs kids. And the crazy part with that population is that they get hit almost every single day. They only come in when it's like a really bad injury or when they're really, really hurt, but they get beat up just about every day, and it's very unfortunate. So something like that where, they can't really accommodate, but that's not up to you, right? It's up to the employer. So always focus on the patient and the actual injury. So we just write the restrictions and then we let the employer take care of the rest. Now, what is supposed to happen if they can accommodate, they'll have them doing a light duty, or sometimes if they can't, then they'll just take them off of work. Again, that is on the employer, all right? So with restrictions, there's 3 different sections on the standard form. It's no restrictions, it's the ones with, okay, the restrictions start from this day to this day. And then the last one is typically take them off of work. Let me tell you this, it is a very rare occurrence that you're gonna take a patient off of work, okay? That's usually if like head injury with LOC, they had to go to the hospital or something like that. Even with that, that's gonna be a very quick follow-up, like 1 to 2 days or something like that. So you will have patients that will push and they'll say, oh, well, if you can just give me a few days off, then yeah, I can get. So I always hit them with this line: we don't take you off of work, we write the restrictions, and then your employer will kind of determine what is gonna happen from here. You might get some pushback, but that's just what it is. But you are almost never gonna use that last line to take them off of work, unless it's one of those injuries where they can't do their job, like if it's something that's very severe. But usually at that point, somebody else may be involved with the case, either a specialist or your medical director. Because the good thing is that a lot of these, we're not going to necessarily be doing these by ourselves. Usually there has to be an MD or DO on board, so it's not like it's just going to all fall on you. So as far as doing that whole taking them off work, that's a very rare thing. So again, most of these will be orthopedic, and so with time, you want to think about function. So not just the injury itself, but you want to get them back to function. So if it's like a shoulder injury, okay, maybe the first time, if it's just like a really bad strain/sprain, yeah, you want to have them in a sling, but with time, you want to try to wean them off of that, because we all know if they're sitting in a sling for 7 to 10, maybe 14 days, okay, you don't want to end up causing like a frozen shoulder type situation. So I'll tell them, hey, wear this during the day, but when you get home, take it off and start to move around and things like that. So definitely start that from the initial visit, because again, you don't want them to get dependent on whatever immobilization device they have, especially if it's a soft tissue injury, all right? And yeah, so just make sure that you are thinking of the injury. Now, it's unfortunate that some employers, they don't care. Like, you'll write the restrictions and they'll still have the patient doing their job. So, and then as far as follow-up, depending on the severity of the injury, their pain, I usually have them come back within 5 to 7 days. Now, if it's a bad injury where they're 10 out of 10 and they're in clinic and they are just in a lot of pain, I usually have them come back within a few days, depending on anywhere from 24 to 72 hours, just to make sure things are going in the right direction, okay? And then as far as, like medications, things like that, of course, anti-inflammatory, muscle relaxer, usually like a meloxicam or cyclobenzaprine, something like that. Those are the most common ones that you're gonna see. So just make sure that all areas of that form are filled out, but especially from the first visit, you wanna make sure that they're resting that area. So like with knees and ankles, definitely, you want them to stay off of that. Like if they can't put pressure, that's a difficult thing. So, and again, it depends on what they actually do. Because again, going back to teachers, I get a lot of them, that whole, it's like certain things, they'll even tell you like, I can't do that for my job. So certain things for that population, it may take a little bit longer just because they're still gonna do their job, or they may not have a teaching assistant and it's just them and their 28 kids, and so they're gonna keep kind of going to their job. And so certain areas, you just have to kind of be a little flexible and open-minded, all right? So yeah, that's pretty much it. So just make sure that the mechanism is well documented, you get the full story, because again, you want to clarify, because I've had cases where they get the story and then weeks into it and they come back like, oh, well, they had a previous injury, and then that just kind of sets the whole thing off, because there have been cases where they could be 2-3 months into the case, and then they'll come back after they found something early on where they said they had a previous injury, and then they'll deny the case, and then all of that, it can get very messy. So just make sure you get that from the get-go. And again, you may have to either verify with the employer or your medical director or supervisor staff, okay? Document very well. Again, you may have to double, maybe even triple chart sometimes, but the documentation is the entire case. And then as far as treatment, and then make sure your restrictions tie into the injury. But the goal with each follow-up is that they are hopefully improving the function, because you want to get them back quick, not just have them kind of sitting at home, just not doing much, okay? All right, so that's pretty much it. I do have other videos that's going to tie into this series, so stay tuned. As always, practice boldly, and I will see you on the next one.